Welcome back to the deep dive. So today we're attempting a feat of anatomical cartography.
A massive undertaking, for sure.
It really is. We are navigating Chapter 81 of Gray's Anatomy, which covers the entire incredibly dense interconnected network of the body's vascular and lymphatic systems. This deep dive is basically a guided tour of all the essential plumbing that keeps the engine running.
And the real challenge here isn't just memorizing names of vessels. It's about understanding the relationships, what's anterior to what landmark signals a turn, and what backup systems, what collaterals are in place.
Absolutely. So our mission is to take this textbook map and really try to build it as a three-dimensional reality in your mind. We'll start high and work our way down, beginning with the big pipelines to the head and neck, the carotid arteries.
Right. So the journey begins with the common carotid arteries, or the CCAs. They ascend up the neck side by side until they hit the level of the upper border of the thyroid cartilage.
And that's the spot.
That's where the critical split happens, the bifurcation.
And the split is just fascinating because it immediately sets up two totally different jobs.
It does.
You get the external carotid artery, the ECA, which handles the face and the neck exterior, all the superficial stuff. And then the internal carotid artery, the ICA, which dives inward.
Dives inward to supply the really critical contents of the cranium in the orbit.
And right away, there's a key difference depending on the side.
A very important one. On the right side, the CCA comes off the brachiocephalic trunk, so it's relatively short. But the left CCA is longer. It arises directly from the aortic arch itself.
So the left one has a piece in the chest and a piece in the neck.
Exactly. A thoracic and a cervical component.
Now, if we picture this region in the neck, the sources make it clear these vessels aren't just running loose, they're bundled up.
Yeah.
Can you walk us through what's inside that carotid sheath?
Of course. So you should picture a neat little package. Inside that sheath, you've got three main things. The common carotid artery, obviously.
Right.
Lying lateral to it is the big internal jugular vein. And then tucked in behind, sort of nestled between the two, is the vagus nerve.
That neat package is such a recurring theme in anatomy. Now, right at that bifurcation point, before the ICA and ECA really go their separate ways, there are these two tiny but monumentally important organs. Let's start with the carotid sinus.
The sinus is, it's often just a slight dilation, usually right at the lower end of the internal carotid artery.
Yeah.
This is your body's main baroreceptor.
The pressure gauge.
It's a pressure gauge. It's constantly monitoring and helping to regulate your systemic blood pressure.
And right next to it, sharing that space, is the carotid body. Why is that one just as vital?
Well, if the sinus is the pressure regulator, the body is the chemical alarm system. It's this small reddish-brown thing, a chemoreceptor.
Okay.
It's constantly tasting the blood, looking for distress signals.
Right.
Low oxygen, high CO2, low pH. And when it senses trouble, it fires off signals to the brainstem, mainly using the glossopharyngeal nerve.
That location makes so much sense, sitting right where the blood splits to go to the brain. Now let's follow that internal carotid artery, the ICA, up towards the skull. What's the one thing a surgeon needs to know to identify it in the neck?
This is such a high-value clinical insight. The internal carotid artery has virtually no branches in the neck.
Wow.
None. That absence of branches immediately tells you it's not the external carotid, which is already throwing off several branches nearby.
So if a surgeon sees branches, it's the ECA. A clean trunk heading straight up. That's the ICA. That's a huge diagnostic shortcut.
It's a massive one. The ICA's journey is in 4 parts. Cervical, then petrous through the carotid canal, then cavernous, and finally intracranial. And that petrous segment gives off one small but notable branch, the caroticotympanic artery, to the middle ear.
Okay, let's switch to the external carotid, the ECA. It starts close to the ICA, but then it kind of loops around, becoming more superficial.
Right, and higher up, it's separated from the ICA by the styloid process in its muscles, and the ECA is the one with all the branches.
And all the clinical risks.
Indeed. Take the superior thyroid artery, one of its first branches. It descends very, very close to the external laryngeal nerve.
Yeah.
The relationship is so tight that if you have to ligate that artery during surgery,
You're putting the nerve and the patient's voice at risk.
immediately.
And this is where it gets even more complex. The largest terminal branch of the ECA is the maxillary artery. The sources split this into 3 parts.
Yeah, the mandibular, pterygoid, and pterygopalatine parts. And that complexity means it's super variable, with a really tortuous course through the infratemporal fossa.
And from that first segment.
The mandibular part, yeah. We get the middle meningeal artery. This is the main blood supply to the calvary, the top of the skull. It passes up through the foramen spinosum, and then splits inside.
Okay, jumping back for a second. Once the ICA is inside the cranium, its first big branch is the ophthalmic artery.
Right, it pops out of the cavernous sinus and enters the orbit through the optic canal.
And if we're talking about single points of failure,
Then you have to talk about its first and most critical branch, the central retinal artery. It's tiny, but it travels inside the optic nerve sheath itself
wow.
to supply the inner layers of the retina. This is the whole basis for the blood-retinal barrier. If you block this artery, it leads to blindness. It's that simple.
Okay, that covers the head map. Let's shift down and look at the central highway that feeds all of this, the aorta. The sources describe it in 4 parts: ascending, arch, descending thoracic, and abdominal.
Let's focus on the aortic arch. From right to left, the 3 traditional branches are the brachiocephalic trunk, the left common carotid, and the left subclavian.
The classic textbook picture.
Exactly. But we have to mention the most common variation, the so-called bovine arch morphology.
Which is surprisingly common, isn't it?
It is. In about 7% of people, the left common carotid doesn't come directly off the arch. Instead, it branches off the brachiocephalic trunk. Knowing that is critical for reading scans.
And before we get to the heart, we can't forget the pulmonary trunk. This is carrying the deoxygenated blood from the right ventricle. In an adult, the left pulmonary artery is physically tied to the aortic arch, right?
Correct. That connection is the ligamentum arteriosum. It's just the fibrous remnant of the fetal ductus arteriosus, and it's a really important landmark in the mediastinum.
And then we get to the heart's own supply, the coronary circulation. We all know the left coronary artery, the LCA, is usually the heavyweight.
It's typically larger, yeah. It supplies most of the left ventricle and the septum.
But dominance is different.
Right. Vascular dominance, whether you're right or left dominant, is determined by which vessel gives off the inferior interventricular branch. Usually it's the right coronary artery, so most people are right dominant.
What's so fascinating is how the body seems to prepare for failure. The sources talk about these collateral channels, like the Vieuxen's arterial ring. They're literally described as a built-in bypass system.
It's a very elegant design, but here's the clinical catch. While these connections exist, and they can even grow over time if a blockage develops slowly,
Right.
they're often totally insufficient to compensate for a sudden acute coronary occlusion. The flow just can't ramp up fast enough.
Which is why we need things like a CABG, a coronary artery bypass graft. And it's interesting, the material preference has changed. Surgeons now often use the internal thoracic or mammary artery.
Or the radial artery, yeah. It's because the arterial grafts just have way better long-term patency rates. An artery is built to last under high pressure, so you choose it over a vein whenever you can.
Okay, moving down into the abdomen. The abdominal aorta starts at T12 and splits at L4 or L5 into the common iliacs. Let's focus on those unpaired branches that supply the gut.
Starting with the celiac trunk. It feeds the liver, spleen, and stomach. One of its main branches is the splenic artery, which is famous for being incredibly tortuous. It runs behind the stomach to get to the spleen and pancreas.
And the common hepatic artery splits, but there's a really important surgical risk tied to the right hepatic artery.
Yes, its course is variable. It usually crosses behind the common hepatic duct, but sometimes it crosses in front.
And if it's in front.
It's extremely vulnerable during gallbladder surgery. Knowing that variability exists is what saves livers.
The next big one, the superior mesenteric artery, or SMA, is vital. It supplies everything from the midgut.
And its branches to the jejunum and ileum are structured brilliantly. They form these looping arterial arcades, which then send off street arteries, the vasa recta, to the gut wall.
Which gives it massive redundancy.
Huge redundancy in the intestinal supply.
Now, for one of the highest stakes vessels in the entire body, the artery of Adam Kivitz.
Oh, yes. The name alone sounds ominous.
It does.
It's formerly the great anterior segmental medullary artery. This is the lifeline for the lower two-thirds of the spinal cord. It usually comes from a lumbar artery high up L1 or L2, and most often on the left.
So if you're doing an aortic repair and you accidentally compromise that one single artery,
the result is catastrophic. Spinal cord infarction. Paralysis below that level. It just shows how critical one tiny asymmetrical vessel can be.
let's move to the pelvis and lower limb. The internal iliac artery supplies the pelvis, perineum, and gluteal region.
And you have to visualize the crazy path of the internal pudendal artery. First, it has to exit the pelvis through the greater sciatic foramen.
Okay.
Then it has to loop immediately around the sharp ischial spine and then re-enter the pelvis through the lesser sciatic foramen.
It's doing a three-point turn to get where it's going.
Exactly. And it does all this while running in its own little fascial tunnel, the pudendal canal, or Alcock's canal. It's the ultimate protected route to the perineum.
Down in the leg, the external iliac becomes the femoral artery. It stays the femoral until it disappears through the adductor hiatus. Then it's called the popliteal artery.
And its largest branch is the profunda femoris artery. This gives off the perforating arteries which pierce the adductor magnus. And these are important because they form a crucial double chain of anastomoses deep in the thigh. Huge collateral flow.
And then around the knee, the popliteal throws off all the genicular arteries.
Superior, inferior, medial, lateral, middle. It creates a literal web of arteries around the joint.
And that dense networking brings us right into modern surgery, the angiosome concept.
Right, which maps out these vascular territories. It defines which patch of tissue is reliably supplied by one specific tiny vessel.
And that's essential for things like perforator flaps, like the anterolateral thigh flap, the ALT flap. Surgeons can isolate these tiny vessels and move huge pieces of tissue around.
Or a vascularized fibula graft for mandible reconstruction.
Surgery isn't about avoiding vessels anymore. It's about depending entirely on preserving one tiny artery and its vein.
Okay, let's flip the switch. Venous drainage systems. Starting in the brain with the dural venous sinuses. There's unique.
They're very unique. They aren't true veins. They're channels between layers of the dura mater. And most critically, they have no VLLVs.
And that lack of valves is a huge problem because of the emissary veins. Exactly. The emissary veins connect these sinuses to the veins on the outside of the skull. They're an alternate drainage route, but with no valves, they're also a bidirectional highway.
For infection to travel from, say, a scalp wound straight into the brain's lining.
Precisely.
In the thorax, the internal jugular and subclavian veins join to form the brachiocephalic veins, which then form the superior vena cava, the SVC.
And you can't talk about the SVC without mentioning the azygos system. You have the azygos vein on the right and the hemiazygos veins on the left. This whole system is a critical built-in collateral pathway.
Meaning if the SVC or even the IVC gets blocked,
The azygos system can basically take over drainage for the whole torso. It's an essential venous detour.
down in the abdomen, we have the specialized hepatic portal system. The portal vein is formed behind the pancreas by the splenic vein and the superior mesenteric vein coming together.
And when pressure builds up in that system, portal hypertension, the blood is forced to find shunts back to the systemic circulation.
And that's when you see things like esophageal varices.
Or caput medusae, those dilated veins around the umbilicus. It's blood trying to find an escape route.
Let's end the venous section on a really crucial, high-yield clinical point from the sources about the renal veins. There's a massive difference between the right and left.
This is one of those rules you absolutely have to remember. The left renal vein is much longer, and it receives important tributaries, the left suprarenal and left gonadal veins.
So it has backup drainage.
It has collateral flow. So you could potentially ligate the left renal vein medial to where those veins drain in, and the kidney might be okay.
But the right renal vein,
Nope. The right renal vein has no significant collateral drainage. You cannot ligate it with impunity. If you do, you cause severe congestion and probably kill the kidney. That anatomical difference completely changes the surgical approach.
that's a perfect example of why this stuff matters so much. Okay, finally, the lymphatic system. Where does all the lymph end up?
Almost all of it drains into one central collector, the thoracic duct. It starts in the abdomen, at the cisterna chyli, around L1 or L2. Then it ascends, crosses over to the left side in the thorax, and finally dumps into the venous system where the left internal jugular and left subclavian veins meet.
And understanding lymph node drainage is just foundational for oncology. For the breast, drainage is mainly to the axillary nodes. But surgery there has a specific nerve risk.
It does. During an axillary dissection, the long thoracic nerve is always at risk. If you damage it, you paralyze the serratus anterior muscle, and you get that classic clinical sign, scapular winging.
And one last great rule for the retroperitoneal space. Where do the gonads drain their lymph?
They follow their blood supply. Lymph from the testes and ovaries drains way up high to the lateral aortic nodes around the L2 level, which is where their arteries originally came from. That's why testicular cancer can present with abdominal pain.
So, we have completed this incredibly dense, high-speed deep dive into the body's fluid systems. We've gone from chemoreceptors in the neck to the azygos system and the critical differences in the renal veins.
And as we close, let's reflect on this constant theme from the sources. The body is engineered with so much redundancy. Coronary collaterals, the azygos shunt, arterial arcades everywhere.
A built-in plan B.
Right. So if the body has this high degree of backup engineering, what physiological or evolutionary factor explains why those collateral pathways so often fail to compensate during an acute crisis, like a sudden heart attack or major trauma? Why do they demand such rapid external medical help to prevent a catastrophic outcome?
It's that huge gap between chronic adaptation and acute failure. A great question to ponder. Thank you for taking this deep dive with us. We hope you feel thoroughly well informed and ready to visualize this intricate network.